Hello and welcome back to our second session for the Ontario Network of CAPC CPNP projects, day one of our online conference. And I'm really pleased to introduce our next speakers. We have Lavonne Harms and Vivian Qiang, who are joining us, and they're going to speak about, you can see their slide here, considering structural barriers to health equity using SGBA Plus approach, and they're going to tell us all about that. So I'm pleased to hand over the session to Vivian and Lavonne. Over to you.
Great. So welcome, everyone. Thank you for attending our session today. And Vivian and I are really excited to be here with all of you. So I'm going to introduce myself as Lavonne. My pronouns are she, her. And before we begin, I would like to acknowledge that I am a white speaking to you today from the Prairie Land. I am in Winnipeg, Manitoba on Treaty 1 territory. And here I live on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. I want to acknowledge that settlers like myself are responsible individually and collectively for the violence and oppression Indigenous peoples have and do continue to endure. My commitment to actively advance reconciliation, because it is an active stance, is to continually engage in active listening, learning, and unlearning. And I invite each of you, as you move throughout your day today, to reflect on your own personal commitment and what does it mean to take an active stance towards truth and reconciliation. And before I hand things over to Vivian, she's going to start us off with our session, and then I'll end with you today. I just wanted to mention that I have had the privilege and the pleasure of working as a public health dietitian in a CPNP program in Winnipeg. So I spent over 12 years helping to facilitate, prenatal, postnatal programming. And honestly, I wanted to just come today and just sit and start to swap stories of the amazing participants that attend these programs and the fantastic work that all of you do and you engage in, because I've been a part of that work. But, organizers had sort of a different idea. And so here we are, and perhaps another day we will be able to meet again and we can chit chat about all the amazing things that you do. So Vivian.
Thanks so much, Lavonne. My name is Vivian Qiang, and my pronouns are she, her. I'm speaking to you from Tiohtià:ke, which is colonially known as Montreal, and this is the traditional and unceded lands of the Qiang, Haudenosaunee, and Anishinaabe nations. I identify as a racialized settler, and therefore I recognize that I live and work on stolen land and am a continued beneficiary of the colonial systems that exist in Canada today. And I also acknowledge that though these acknowledgements are very important, they are far from enough. And so my journey of learning and unlearning continues way beyond this land acknowledgement. And I urge you to take some time to reflect on the history and ongoing legacies of colonialism where you are at as well. So as mentioned, Lavonne and I serve as policy analysts on the Health Equity Integration Team, or HEIT, at the Public Health Agency of Canada. And HEIT essentially serves as the focal point for Sex and Gender-Based Analysis Plus, or for short, SGBA Plus at PHAC. This means that we are really the lead for building capacity to support the integration of intersectional analysis and health equity considerations into policies and programs throughout the agency. So just to provide a quick overview of our presentation, we're going to start by walking through some key principles and approaches related to health equity and intersectional analysis. Then we're going to learn about how to monitor health equity outcomes, and then finally apply all that we've learned to a practical example. So starting with health equity concepts. First of all, I want to begin with an introduction of the SGBA Plus policy, as this really gives us permission to be here and talk to you today. Within the agency, advancing health equity is supported by our Health Portfolio SGBA Plus policy, which was renewed in 2022. This update represented a significant shift from the 2014 version, which focuses more on sex and gender differences, to really emphasizing now the importance of adopting that intersectional lens to advance health equity. PHAC also includes the S in SGBA Plus to acknowledge the role of biological sex in influencing our health outcomes. We also want to emphasize that although the name of the framework only mentions sex and gender, SGBA Plus is really an analysis approach that considers all structural and social determinants of health, which we'll delve into a little bit more later. So now you can see this word cloud really includes concepts and approaches to public health and healthcare practice, and I'm sure you're familiar with many of these. SGBA Plus is actually the terminology used by PHAC to action these public health approaches. And when we say that we're using this SGBA Plus approach, lens, or analysis, we mean that we're integrating health equity considerations in all of our work, regardless of the department, team, or role that we play. And this is also the overall vision of population and public health work, regardless of the jurisdiction. So you've likely heard and used the term health equity for many years. In fact, from what I know, many of your programs very much exemplify the importance of health equity in public health practice, and I'm really honored to be here and learning from all of you as well. So health equity exists when all people can reach their full health potential and are not disadvantaged from attaining it because of their race, ethnicity, gender, socioeconomic status, sexual orientation, or any other social position or identity. And when we're talking about advancing health equity, we are referring to it as both a desired state and a practice. Health equity as a practice is an ongoing and responsive practice to historical and current systems of colonization, oppression, and other structural barriers. And I also want to acknowledge that we've been increasingly hearing about equity, diversity, and inclusion as buzzwords that are used in research, media, and beyond. But it is critical for us to acknowledge that equitable practice is a competency and a culture that we are continuously striving toward. So I want to start off now with a quick little exercise. So you can join our poll by visiting slido.com and inputting that number below, or you can scan the QR code with your phone. And so I want to ask you, which of the following are examples of health equity in practice? And you can vote for as many options as you think are appropriate. And feel free to let us know if you have any issues joining as well.
Sorry, we should have warned you that you needed to have your phones handy.
You could also do this on your computer too. Oh, I see people.
You can, yeah.
You can open a new tab, a new website on the computer or over the phone.
Mm-hmm. Thank you, Sydney. Okay, wonderful. We're seeing some responses trickle in. This is great. I see a lot of us agreeing on the same options here. I'll just wait a couple more minutes so that everyone who wants to engage can. All right, so we're seeing clearly that there are three options that we've all pretty much agreed are examples of health equity in practice. So we see considering the needs and experiences of diverse communities at the very beginning and throughout the program development cycle. So this is very much an example of health equity in practice. We're not, only aiming to engage with communities at one point or after the start of the program. It's really a continuous process of building trust and meaningful relationships. The second option is continuously reflecting on our personal biases and positionalities related to the communities that we work with. And this is so important because we need to think about how we are impacted by these systems of power and privilege and the potential power imbalances that might exist between the people that we work with, our individual social identities, and the organizations that we are a part of. So that is absolutely a great example. And finally, we see acknowledging the historical and systemic context of the community's health inequities. And again, this is so important because we're really thinking about the broader social, political, and economic contexts influencing the issue. And we'll really delve into these a little bit more. And we see that, health equity impacts as only a one-step checkbox activity is not at all sufficient. We really want to avoid these kind of more performative attempts at health equity that are just a one-step issue. And so, we want to be embedding health equity throughout our activities and decision-making processes. And it is, again, a goal that we are continuously striving toward. So thank you so much for participating. So we've talked about health equity. On the other hand, health inequities are disparities that are unjust, avoidable, and unfair, and can't be understood or adequately addressed if we focus on only individuals, their behavior, and their biology. So health inequities are produced and sustained by deeply entrenched social norms, narratives, and systems such as individuals, a pull yourself up by your bootstraps mentality, as well as gender roles. And inequities result from oppressive systems and ideologies, including racism, colonialism, ableism, among others, that intentionally and unintentionally prevent people from reaching their full potential. So here are some guiding principles that are a part of the SGBA Plus policy. So equity asks, who is trying to get in the room but can't? And why can't they? Is it because of structures and systems of oppression? Diversity asks, who is in the room? And are diverse perspectives being represented? But are folks standing in the back, or do they have an actual seat at the table? And finally, inclusion asks whether everyone's perspectives are being heard. This again considers the insidious nature of power and oppression. Even having a seat at the table doesn't always allow you to be heard. We can then go even further to consider, should there even be a room and a table in the first place? And can this be reimagined? And what could that look like in your context? So we're going to do another quick activity related to health and healthy living. In the chat, please write down some of the top healthy lifestyle tips that you often hear or read, whether that be in magazines, blogs, or amongst your family and friends. And we'll give you a couple of moments. Okay, Robin is saying eat less, move more. Absolutely. Lay is saying walk. Amanda, sleep. Definitely something that I need to catch up on. Sheena is saying stay hydrated, drink water. Same with Melanie. Colleen, quality sleep. Robin, just do it. Yeah, that's a good one. Sleep when the baby sleeps. A very common one as well. Yeah, exercising regularly, physical activity. For sure, there are so many of these lifestyle tips that we're often hearing, from doctors, from our friends and family. Now, what your doctor often does not tell you is that these are the top 10 factors for how to live a healthy life. And you may have seen something like this before, but one of them is don't live with low income. If you can, stop. If you can't, try not to live in poverty for too long. Live near good supermarkets and affordable fresh produce stores. Live in a safe neighborhood with parks and green spaces nearby. Work in a rewarding and respected job with good compensation, benefits, and control over your work. And if you do work, don't lose your job or get laid off. Take family vacations. Make sure you have wealthy parents. So having that intergenerational wealth. Don't live in damp, low-quality housing, and so on. I hope it's clear that many of these situations are often not within our control as individuals. Since the mid-1990s, public health practice experienced a critical shift in focusing from individual risk factors and behaviors to the societal conditions that keep people healthy. Factors like adequate income, meaningful work, education, community connection, and decent housing are so important. And we are now thinking about factors or living conditions that cause adverse health outcomes. But even beyond these material circumstances, we can think about the systems and structures that have historically and continue to place people at varying levels of exposure to health risks. So in this activity, we saw that in addition to our individual genetics and lifestyle choices, where we are born, grow, live, and work also have an important influence on our health. Determinants of health are the broad range of personal, social, economic, and environmental factors that determine individual and population health. And the main determinants of health that we have all come to recognize are those listed on this slide. However, this is not at all an exhaustive list, and we really need to be thinking deeper about the systems and structures that contextualize many of these factors. In public health, we commonly refer to the social determinants of health, and these are the specific group of social and economic factors within the broader determinants of health and relate to how people are positioned in society. When we talk about these determinants, we generally focus on the conditions of daily life, which are fundamental to the lives we are able to lead. The type of job we have, the amount of income, the quality of housing, and so on. While it is very important to recognize and acknowledge these social determinants, we can't just stop there. We must also consider the structural determinants of health that are the fundamental drivers of inequities in the conditions of our daily lives. These are the political, social, cultural, and economic structures or systems that determine how power, money, and resources are distributed across populations. For example, the historical and ongoing impacts of colonialism, which is a system of oppression, contributes to imbalances in power and resources, thereby resulting in the health inequities experienced by diverse Indigenous peoples. And we also need to recognize that health outcomes are always more complex than a simple path from intention to action. The structural and social determinants of health are complex and interconnected. They can't be isolated in ways that behavioral and lifestyle health promotion and disease prevention messages have tried. For example, people who live in areas without access to nutritious food cannot simply eat healthier without addressing those structural barriers. Although public health discusses and reports on the social determinants of health that lead to health inequities, sustained actions are very much needed to address those systemic barriers. Now let's talk about how we can apply these key concepts to principles and approaches. So we're going to be talking about three today. One is intersectionality, then targeted universalism, and upstream. So growing from the work of Black feminist scholars and activists such as Kimberly Crenshaw and Patricia Hill Collins, intersectionality states that individual identities such as gender, race, sexual orientation, and others overlap and intersect and exist within structural forms of oppression and privilege like sexism, racism, and heteronormativity. As much as it's helpful to say what intersectionality is, it's also helpful to say what it isn't, as the term is increasingly being used and misused in various fields. So intersectionality is not merely a tool about identity. It is important to reflect on personal identity, but that must also include a broader discussion on systemic disadvantage and advantage, and the emphasis on these systems and how they work together to shape experiences of health inequities. So SGBA Plus is an intersectional approach that advances and actions health equity. On the screen, you'll see the SGBA Plus intersectionality graphic. The flower in the middle represents individual social identities like race, age, and income that intersect and overlap. And these identities exist within a context of group membership and your community, such as peer groups and social networks. Then if we move further outside the circle, we acknowledge the social context, which are the dominant social norms and narratives that are deeply rooted and ingrained in society, like gender norms. And then that outer circle represents those structures of power and oppression, such as racism, ageism, and classism, which are interwoven to create compounding experiences of privilege and discrimination. So it's important to remember that inequities are never the result of single or distinct factors, but rather they are outcomes of these complex interactions. And next we'll talk about targeted universalism. So in public health, we often have two main approaches in our programs and interventions. universal and targeted, and both have their distinct strengths and challenges. So firstly, a universal approach applies to an entire identified population, but may particularly advantage certain people who are already in privileged positions. So for example, we want to open a new community health center that aims to serve all people in a particular neighborhood. However, those who have transportation options, health insurance, and access to health information will likely benefit disproportionately from this new clinic, whereas those who already experience challenges accessing care will likely face similar barriers with accessing the new health center, unless specific accommodations are made. And this is where the targeted approach comes in. These interventions may apply to a priority subgroup within the broader population. However, the challenge with this approach is that it may only address the consequences of inequities rather than their causes. As a solution, many public health initiatives combine the two approaches, which we call targeted universalism. And this blended approach takes a universal objective, such as increasing immunization rates, and then identifies the specific barriers addressed by certain communities and tailors the program to address those challenges. So during COVID-19, we saw an excellent example of targeted universalism in practice. While vaccine clinics were popping up all across the country, we realized that they were not always accessible to First Nations, Inuit, and Métis populations due to various structural barriers. So in response, Manitoba opened 5 Indigenous-led immunization clinics specifically designed to serve Indigenous peoples living in urban centers, which meant that they were able to provide holistic and culturally safe care that was tailored to these communities' distinct needs. So now moving on to our last approach, which is upstream. So I'm going to play this video, and please give me a thumbs up if the audio works.
You're standing on the edge of a river. All of a sudden, a flailing, drowning child comes floating by. Without thinking, you dive in, grab the child, and swim to shore. Before you can recover, another child comes floating by. So you dive in and rescue her as well. Then another child drifts into sight, and another, and another. Eventually, hopefully, some wise person will ask, who keeps chucking these kids in the river? And they'll head upstream to find out. Every time we have to clean up an environmental disaster, every time a young person winds up in jail.
Oh, sorry about that.
Every time people have to take medications to make up for the fact that they couldn't afford good food. We're suffering from the results of downstream thinking. Thinking upstream means making smarter decisions about what kind of country we want. What better goal could Canada have than creating the conditions for all people to enjoy true health and experience physical, mental, and social well-being? It's the best way to measure our success, and upstream thinking is the way we get there. Help us make the mainstream look upstream. Visit us at thinkupstream.net to find out more.
Okay, so with that video, this is also another graphic that we can start to visualize what downstream to upstream interventions might look like. So when we refer to downstream programming, we are focusing on addressing the immediate health needs of populations, such as providing emergency healthcare and medical interventions. And this seeks to increase equitable access to health and social determinants at an individual or family level. And then if we move down the stream, we get to the midstream determinants. And this is where we are seeking to improve the material working and living conditions, or attempting to reduce the risk of illness by promoting healthy behaviors. Here we can start to consider how to build community capacity and cohesion to develop more sustainable and culturally competent solutions. And finally, we can move to the upstream determinants. And these are the systems and policies that disadvantage and exclude certain populations. So for example, racism, colonialism, and those other structural barriers. And these create institutional and social inequities. The interventions here often involve advocacy and policy level changes. Oftentimes, our work falls within the downstream areas. So for example, providing one-on-one support, home visits, or providing support services such as access or referral to health professionals. And while these downstream interventions are critical, we can also begin to think about how we can move up the stream to address the living conditions that influence individual choices and health outcomes, as well as the social, economic, and political contexts in which we work. So here are some questions for you to start thinking about as we want to start moving up that stream. So how can we shift from only addressing the consequences of health inequities to also considering its root causes? What are the conditions, systems, and policies that shape lifestyle choices and impact health outcomes? Are there any opportunities to strengthen social cohesion and community connection to build resilience against systemic racism and other structural barriers? And how can we potentially partner with organizations or institutions who do work at that policy level to collectively advocate for systemic change? So we have our final Slido activity. So please log back on to slido.com on your computer, or if you're on your phone, open up that window again. And here we're asking you to rank the following interventions which aim to address the issue of housing from downstream to upstream. So the options are meeting with elected officials and citizen groups to advocate for more affordable housing, bringing stakeholders and partners together to improve the enforcement of regulations, to improve poor housing conditions, as well as increasing the availability of allergy and asthma treatment to children who live in vulnerable situations. So I'll give us a couple of minutes to rank.
To be honest, Vivian, I'm not quite sure how this works. Like could you say, so the first one I choose is downstream, and the second one I choose is midstream, and the third one is upstream?
Exactly, yes.
Okay.
So
Okay.
again, first is downstream, second is
Okay.
mid, and third is upstream. Thank you, Sydney.
Thank you.
So what you're going to see on the slide is essentially they've assigned points to each of them, and they're going to rank them based on how we've been voting. So once we've all voted or ranked the options, we'll kind of break it down and explain it.
Just wondering also, Vivian, if people are comfortable and are having trouble accessing the website, they could maybe put in the chat, what they think. Number one, which one it is. Number two, which one it is. Number three, which one it is.
Absolutely, yeah. Absolutely, yes. Please feel free to use the chat. I know that Slido can be a little bit confusing sometimes.
Thank you.
Absolutely. So I'll just give it a couple more minutes so that folks who want to use the chat can. Okay, I think the voting has stabilized. So this is absolutely the correct order. So the downstream option here is increasing the availability of allergy and asthma treatment. And this is trying to fix the consequences or health outcomes of poor housing conditions. So that would be considered downstream. For the midstream option, we're bringing stakeholders and partners together to improve the enforcement of regulations. And this is, again, focusing on the application of regulations or policies to directly address the living situation. So this is what we would consider midstream. And then finally, at that upstream level, where we're meeting with elected officials and citizens groups to advocate for more affordable housing, this is really trying to strive towards policy level change that addresses the root cause of housing issues and trying to create policies that would increase affordable housing. So great job, everyone. Thank you so much for bearing with us with Slido. And now I'm going to hand it over to Lavonne for the second half of the presentation. Thank you.
All right. Thank you very much for engaging with Slido. I know it's tough to try to figure out how to do an engaging session virtually. So thank you for figuring that out. And thank you, Vivian, for the first two sections. And she set us up nicely to think about how do we move forward? What does it look like to monitor equity outcomes? And then we're also going to talk a little bit about that and then move into going through a case study example together. So our favorite, I'm sure, disaggregated data. Now, it's fortunately, or fortunately, I guess it depends on how, sort of your love-hate relationship with data. But the first step towards identifying and monitoring health inequities is to collect and use disaggregated data. And that's data that, has been disaggregated, broken down by more of those individual social identity factors that Vivian mentioned earlier when we're thinking about that inner circle of intersectionality. And collecting data on these various identity factors really help us to identify and then ultimately address those health disparities that exist within our broader population. And so we've got an example here for you. So during the pandemic, Manitoba Health started collecting and reporting on COVID-19 case counts, disaggregated by race, ethnicity, and Indigenous identity. And so we've got the figure here for you on the right side of this slide. And during this time period of collection, you can see that there were higher rates of COVID among racialized and Indigenous communities with varying trends across the population. But what's really key here is that this data was directly used to inform planning and initiatives that met the needs of populations through better informed vaccine eligibility. This is all what happened in Manitoba, and placing vaccine and testing sites in trusted places in communities. So the example that Vivian gave about the COVID vaccine sites that were placed in the 5 urban Indigenous community areas, that was directly, information that, or it was informed by this race data that came out. And so, although we know that communities know the health inequities that they experience and also know what interventions, programs, initiatives they need, the disaggregated data that was collected becomes really powerful for providing the evidence that decision makers need to be able to actualize the programs and interventions that community request and ask for. So at every stage of a program or an initiative, it is important to gather this data on the different socio-demographic and socioeconomic factors to help identify gaps, and then to also help us monitor and evaluate our impact. So we need to think about the data collection not just as one point in time, but how it actually continuously can help us to monitor and evaluate our programming. We also need to remember to identify and challenge our own assumptions and biases related to data collection and use. And then also there's many different ways to gather information. We've listed some of them here, and I'm sure many of you have other examples of what's worked best within your context. So we want to acknowledge that there are clear harms and risks associated with collection and use of data, especially for communities who have been targeted and over-surveilled, folks who are asked the same questions over and over and over. And it's really important that as we think through this idea of collecting data, that we are transparent and open with the purpose and the use of the data collected. So perhaps this involves inviting community members to engage in conversation, discuss any questions or concerns that they have. If possible, being able to meaningfully collaborate with community members throughout the data collection process. So this is even with how you determine what you use to collect the data, right? Whether it's a sharing circle or a survey or a focus group. And this helps to ensure that perhaps any approaches are developed with the community safety in mind. Another idea is perhaps participants may feel more comfortable collecting or completing an intake form on their second visit versus their first visit, right? Instead of sort of handing the papers to all the people. Are there different ways that we can also think through collecting this sort of data that fit based on the context of where you work? And then, of course, being able to return that knowledge gathered and analyzed back to the community, and the accountability through proper data governance are key. So way back, Vivian mentioned the SGBA Plus policy, which kind of guides some of this work within the Government of Canada and the Public Health Agency, which also directly kind of flows into the way into program funding. And this policy, during its revision, really places an emphasis on the importance of disaggregated data. And I really like this kind of quote or this statement, because without that information about pre-existing inequities that emerge from continuous collection and analysis of the data, designing appropriate public health responses that address inequities is difficult. And I think something to think about here is that when the pandemic hit, all of a sudden, everybody was talking about inequities, right? And about the disproportionate impacts of communities. And these are all things that I know that you all know that these things existed because you work in community. But it all of a sudden kind of became this new thing. And we're sitting here, right, all of us, well, nothing's new about this, right? But what happened during COVID is it actually brought it to light. And to help us ensure that we continue to think through inequities when we're designing programming and policy, we need to keep that at the forefront of decision makers' minds, right? So that it doesn't kind of sort of fall to the wayside again. And ensuring that we have that continuous collection of this data to help us create and craft those narratives and those stories about what's really happening in community is really, really important to help us eventually try to get to those equitable outcomes. A note on collecting data that's specific to sex and gender. In 2018, a policy was introduced in the Government of Canada to modernize sex and gender information practices. And this policy emphasizes the need to collect data on gender by default and then only sex when required. And we want to ensure that we understand that sex and gender are two separate concepts and they're often conflated, right? And so sex is assigned at birth and determined based on biological characteristics. So this is when you identify as male, female, or intersex. Now, gender is a socially constructed identity. This is where an individual can self-identify as a man, woman, or a gender diverse identity. And a person's gender can change over time. So the policy, the 2018 policy, really works to respect gender diversity, recognizing again that gender is a spectrum rather than this binary concept. So through the policy, program areas are now asked to include a non-binary gender category where gender information is collected and used to ensure that all are represented. And so an idea for this in practice, one way that we can promote gender inclusivity is, again, thinking about how we craft our surveys and the demographic data. And we could offer other options such as non-binary and two-spirit. And many of you are likely already engaging this kind of work and are up to date with kind of this understanding of how we need to ensure we don't conflate the two. Okay, let's move on. We're going to talk through a scenario and a little case study and show you what it means to apply this SGBA Plus process. First, fresh off the press is this resource, and it was created by folks on our team to support any organizations that are applying for PHAC funding and support them on how to integrate health equity using this SGBA Plus language and approach. And today we're going to use this guide and the SGBA Plus 5-step process to sort of walk through a case study example. And we've hyperlinked the guide on the slide. It is available online for anyone. And I saw a comment earlier in the chat that yes, the slides we will be sending them over to Sydney in English and French. Okay, so here's the 5 steps. There's nothing really special about these steps. They're the same thing that any of us would use when we start this process of thinking about how we're going to design or we're going to plan a program. There's just one key difference, and that is at every step, there is the explicit incorporation and consideration of key self-reflection questions to help challenge our own personal assumptions and biases. And these questions and considerations help to take us past some of that individual, more downstream level thinking to kind of help us work up the stream and consider the structural determinants of health, like what Vivian was mentioning. There are 5 steps, and you can see that they're not linear. It's definitely an ongoing process. And an important piece to keep in mind is that the way you frame an issue from the beginning can influence everything else in the process, from the data that you collect to the program and monitoring options that are developed. So this slide includes a few of those key reflective questions at each stage, and there's many other examples included in that guide that I mentioned. And what I'd like to highlight here is the need to gather data all along the way at each step to help inform your analysis or your needs assessment, monitoring, or evaluation. And again, this data could look, there's a multitude of ways, right? It could be that qualitative or it could be quantitative data. Or is there information from provincial reports you can find? Other community assessments, perhaps from your local health authority. And this will all depend on the context and the type of program. So here's our scenario, and I'm just going to read it through with you. So you're working on an outreach team of a local community-based organization and notice an increase of newcomer families moving into the neighborhood. While programs exist in the community that do support families broadly, staff on the outreach team continue to hear comments from newcomer individuals who are pregnant, highlighting barriers in accessing prenatal and/or postnatal care. The director of your organization is aware of a new funding opportunity and asks you and your team members to prepare a 1-page document that outlines the concerns and issues you have heard from newcomer families, including potential options for programming. So using the SGBA Plus approach, the team is going to follow a 5-step process to propose a responsive and inclusive initiative that will meet the needs of these families. If we were in a much smaller group situation here, we would put you into breakout rooms and help you facilitate and work through all these steps together. But we don't have time for that today. So Vivian and I worked on this together in the background, and so we're gonna just show you what this process would look like. And hopefully this aligns with also what you heard recently in your session, which was, I believe, on needs assessments and such. So this SGBA Plus process framework kind of aligns with this idea of doing a needs assessment. Because first, you got to identify and define your issue. And when defining an issue, no matter your role or responsibility, it's really important to reflect on our own internal biases and where feasible to engage, again, with communities to ensure their perspectives are reflective. So based on our case study, we could ask, what assumptions do we have about newcomer families are expecting? And this could take us down a lot of, different conversations we could have as members of this outreach team. And when defining this issue, we also need to think, again, more broadly than just the individual families. What are those social, political, and economic contexts that are at play? Again, bringing us back to that section on those structural and social determinants of health. So we've worked through these questions, and our issue today is that newcomers to Canada who are pregnant face systemic and structural barriers to access prenatal and or postnatal services that place this population at a greater risk of adverse outcomes. And what's really key here is to show how we position the structural barriers as what's placing this population at a higher risk, right? It's not anything that's inherent related to this population. So it's important, again, to think through and describe those structural barriers. In step 3, we're going to actually name them. So step 2. So who's impacted by the issue and how? How are these folks negatively impacted? What are their histories? What are their experiences with institutions? How have they been shaped by their context? So for our case study, the outreach team has gathered information, right, from various sources, all that data, and identified that newcomer individuals who are pregnant are negatively impacted by lack of timely, culturally competent prenatal and or postnatal care. Step 3, here we want to better understand and identify how and why certain outcomes perhaps differ between and within your priority population. So in our example of the newcomer families, here we want to think about differences in access to programs and services depending on how folks arrive in Canada. We're going to start to think about, is someone coming on an immigrant visa who already has a job? They're still going to experience barriers, system barriers, etc. But are those going to be different than someone who's arrived on a GAR, like a refugee visa, right? Or perhaps temporary foreign workers. So here, again, it's important to think beyond those individuals to those systems and structures that are creating and sustaining barriers and inequities. We want to name them. And we've done this for you today. And inequities in this context exist for newcomers to Canada living with lower income and a decreased access to services based on temporary or refugee status. These are barriers that are created and sustained by the intersecting systems of oppression, like classism, racism, and colonialism. Now, I want to say that steps 1, 2, and 3 are really, really difficult to do in the linear way I just presented. The answers to all of these are often revealed kind of all together if we truly engage in this process and practice asking ourselves those really hard reflection questions. I often think of it that you think of that 5, the circle, your 1, 2, and 3 kind of spin together in their own circle within the larger circle of the steps, because they're constantly reinforming and reinforming each other as you work through sort of your options and then about evaluation. I hope that made sense. But let's move on to step 4. Here, we get to develop recommendations and options. And just to note that it's really typical and normal for our brain at the beginning when we start to identify an issue, we want to go straight to step 4, straight to kind of think through, what are we going to do? What are we going to do about these issues? Especially when we're really, we don't have a lot of time and energy and we see the need. But we really need to take time and be very thoughtful when considering those earlier parts of your needs assessment, of these steps. And then in that way, our programming and our results and recommendations become even more reflective of equity principles and help us think through how do we move further up the street. So we here are, we're going to use this, thinking back to those public health approaches that Vivian went through. And for our initiative, we're going to think about considering that universal pre- and postnatal programs, they already exist within this community, right? So we don't need to duplicate that. So we're going to develop an initiative that prioritizes newcomer individuals who are pregnant. We also want to think through about our program assessments and reports, that the disaggregated data is being collected. We're including self-reflective and reflective questions within our assessments and reports that consider what are potential unintended impacts and outcomes on these priority populations within this group of newcomer folks. Could say so much more about options, but we don't have the time today. And same with step 5. This step is super tricky. At least I find it tricky because many of us have not been trained formally in performance management and evaluation. Step 5 requires, and 4, a way longer conversation, but based on time, we've chosen kind of a couple ways that we could actualize step 4. So again, we just here want to think through our monitoring and evaluation processes, include that transparency and accountability through proper data governance. How's data collected? How is it analyzed? How is it used in ways that reduce potential negative associations and stigma? And then our programs are going to include that meaningful community engagement straight from the beginning, that consultation straight from funding. So step 1, and it's going to flow all the way through to step 5 and help us throughout our evaluation. That was one example of working through an SGBA Plus process. So first of all, we did that really fast for you. It's typically not fast, and there can be a lot of discomfort in considering asking ourselves the hard questions and what's under our control, right? How can we really work through these issues and get to those equitable outcomes? But regardless of the issue, the concern, or wherever we work, we know that this explicit focus on equity as part of our decision-making process can result in more innovative and effective policy and program decisions. And we definitely saw this happen in real time during COVID. Okay, I see that we have got 6 minutes left here. Here's my concluding reflections. Here you go. I'm sure you guys can all sort of take a read through this on your own. I'd rather sort of head to see what we have for any questions or comments. Yeah.
Sure. Let me change the settings here. So if folks want to come on camera, they're very welcome to do that. And I see Amanda has her hand up there. Amanda?
Hi, thank you so much. I just wonder if I'm learning so much, I'm taking this all in, but I'm wondering if you would be available, Lavonne or Vivian, to consult with on just to pick your brain about a specific project, if you're available as a consultant, or how that works with your role at Public Health Agency of Canada. Yeah.
That's a great question, Amanda. And what we actually have is, so SGBA Plus, like it's a policy, right, throughout the government of Canada. And again, it's just another one of these ways, approaches to try to get at equity. And I know that working community, you all are very well versed in understanding equity. Within each region, so thinking about like Ontario region for PHAC, we have typically folks that are participate in a network. So it's called the SGBA Plus network. I think right now in Ontario, there's been a bit of a movement as far as who is on the network and if there's somebody in the network. But those are sort of some folks that would be embedded within the agency to get more information about SGBA Plus specifically, and walking through those steps. And then I would say if your questions have to do sort of with like PHAC grants and contributions, then that would be like, of course, your program officer, right? Like whomever those folks are in Ontario. So I would say probably we can connect in with Blanca, like in Ontario, and then sort of get back to you with that.
Yeah, that'd be great. That'd be amazing. Yeah.
Thank you, Amanda. Anybody else with a question or comment for Vivian and Lavonne before we move into our quiz coffee card giveaway? Oh, I see a question.
Gray media?
Yeah, can you identify the term gray media? Deborah asked that in the chat.
So, Vivian, you go.
Oh, please. I was just gonna say I'm not super familiar with this term gray media. And I was gonna pass it to you, Lavonne, if you have any.
I thought maybe it was in your slide. So I would, well, gray, don't we call like gray literature when we say that's not a scientific, not like a peer-reviewed scientific literature, right? But we know that, again, there's many different ways to find data and evidence, right? So, and I will plunk in the chat a tool from the National Collaborating Center of Methods and Tools that talk about public health evidence. And it's a really great tool to help you think through even that data gathering step when you're developing programming. And I'm thinking the gray media might fall in line with this whole idea with gray literature, right? So it's kind of from that, for the academic world, it's a bit of gathering data and information anywhere other than your like peer-reviewed academic sort of, journal.
Yeah, I would agree with that. I think maybe gray media might have been a bit of a typo on our end, so we apologize for that. It should probably be gray literature with media being an example of that. So thank you for clarifying.
Yeah. Wonderful. Well, thank you both, Lavonne and Vivian. And before we sign off, I've got 3 questions from the presentation to do our coffee card giveaways. So what we'll do is I'll put the question in the chat and also speak it out loud, and the first person with the right answer. And if you've already won a coffee card, please know we're sort of restricting it for 1 coffee card per attendee for the whole conference. So the first question is, health equity is both a desired state and a blank. Process is close, but it's not quite what was shared. Does anybody else have a yes? Brenda Shepherd, that was the answer I was looking for. Thank you, Brenda. So that goes, I'm just making a note here of your name. Congratulations, Brenda. A practice. But I think approach is also, the other words are also applicable for sure. Okay, the second one is, let me just copy paste here. Okay, so inclusion asks whether everyone's blank is being heard. Everyone's blank. Oh, voice is close, but oh, I wonder. It's not the exact word, but oh, an opinion is not quite right. I think, oh, perspective. Yes, Colleen pulled it through there. Everyone's perspective. It's such a shame because the other answers were also right, but just not quite the word we were looking for. So congratulations, Colleen. And let's see here, which was the last one I want to ask. Okay, one more question. So downstream programs focus on blank needs. Downstream, there, Katrina was quick to the keyboard there with immediate needs. So those are our 3 coffee cards for this session. Congratulations to Brenda, Colleen, and Katrina. And thank you once again to Vivian and Lavonne for taking time to come and speak with us today. We really appreciated your insight and information. And thanks to everybody who is here. And I hope you're enjoying day 1 of the conference. And now we are going on I also wanted to point out, I did put a link to the session evaluation in the chat a couple of times. So if you have a moment to share your thoughts on this session, that would be much appreciated. I also put a link to the grand prize ballot for the larger giveaway on that we'll be doing Friday at the conference closing. And that contest is eligible. Folks who live in Ontario and work at a CAPC or CPNP project are eligible for that giveaway as well. And with that, we are going on a break. We have an hour off now, and we'll be reconvening at 1:30 Eastern for our final session of the day. Unlocking the Power of Persuasion with Keisha and Marie Evans on proposal writing. So I'm sure that's also going to be another fantastic session. So enjoy your break, grab some lunch, and we'll see you back here at 1:30 Eastern. Thanks again, Vivian and Lavonne. And
thank you. Thanks again so much.
You're welcome. I hope our paths cross again.
Yeah. Bye.
Bye-bye.